All right, our next presenter is Dr. KG Swan. Dr. Swan is one of our orthopedic surgeons here. He's a assistant clinical professor through the medical school. Did his fellowship at the University of Colorado. Dr. Swan covers numerous high schools within the area, particularly Woodbridge Township High Schools, as well as Perth Amboy. Dr. Swan's going to talk to us about multi-ligament knee injuries. And before he starts his talk, I just kind of want to preface it in that both Dr. Buckley and Dr. Swan see a fair number of really significant multi-ligament knee injuries because we cover a level 1 and a level 2 trauma center. So we're seeing, those big trauma centers, which may be, the number of knee injuries that you may see that with multi-lig, they see probably a good number of them. So he's speaking with some good knowledge here. Go ahead, Dr. Swan.
Thank you, Eric, and do want to take a moment to thank Eric for organizing this whole event. He does it every year, and it's never easy. There's a lot to organize, corralling all the surgeons to get their lectures in on time, and organizing all the AV. Thank you as well to the whole staff. So appreciate the introduction, Eric. So the initial management of knee dislocations. I have no disclosures to report. I've come to learn over the past couple of decades that it is the athletic trainers on the sidelines who are the eyes for all of us. Yes, we have the hands, you have the brains, but I've come to learn that you guys see things that the rest of us don't see. For instance, the blocking back here, number 39, I think it is, who takes the hit to the knee. If you see that, then you know that this player is at risk for a bad injury and the consequences thereof. And it's important to see that. And not everyone sees it. Everyone's watching the ball. But when you see that happen, now you know, okay, what happens next? And why this talk matters is this can be what happens next. This player suffered a knee injury, and the consequences of it were a below knee amputation. And he was brave enough to suit back up and get back on the field with his teammates. But this is what we're trying to avoid. This is what we want to focus on here today. How can we avoid that? So a multiligamentous knee injury is an acute traumatic knee injury involving at least 2 ligaments of the knee. The incidence likely is underreported because many of these can self-reduce. So you see that injury that we just watched on the Packers there, and that may have been a knee dislocation. And if it's not, when you get to it, it may have been, but it reduced itself. So important to see that mechanism and recognize what just happened, because a misdiagnosis here can be catastrophic. So a thorough and timely evaluation is paramount to a successful recovery. We classify these. This is the Schenck classification. It's based on the number of ligaments injured. You can have a 1 ligament knee dislocation, although that's rare. Most of the ones we see probably have 3 ligaments injured, both cruciates, and then one of the collaterals typically is what we will see. You can have a fracture, you can have an artery and a nerve injury as well. This helps us determine sort of the severity of the injury and then make our plan. We sometimes wonder on our side, what's the difference if it was dislocated or if you just tore a bunch of ligaments, but it never quite dislocated? Is there a difference? You might think there is, but until this paper came out, we really weren't 100% sure. But sure enough, if there is a documented knee dislocation, then these players have a less favorable outcome. They have a worse scores afterwards. They have higher pain rates, and importantly, much higher vascular injury rate, up to 45% if we have a documented knee dislocation. But I don't want to ignore the substantial number of players who didn't dislocate their knee, or we don't have a documented knee dislocation, but who still had a vascular injury. So we need to be aware. If it's a high energy mechanism like that, we need to have our radar up. So I just mentioned high energy. High energy is often what we see at the trauma center, the people struck by cars, the motorcycle accidents. And then in the literature, it's often divided into more lower energy, so sporting events and trampolines. But as we just saw, that's not a very low energy injury. It's just not as high energy as the motor vehicle accidents. One that is lower energy and might get missed is what we call the low velocity knee dislocation. This happens in our morbidly obese patients who just step off the curb and dislocate their knee. it may spontaneously reduce. So they come into the ER with a swollen, painful knee, and no one is suspecting that they actually dislocated. And these people have a very high rate of nerve and vessel injury. So that's what happens. If you happen to have a very out of shape and big lineman who twists his knee, put your radar up, because they may have one of these knee dislocations that can have a significant problem as the day goes on. So we're talking about vascular injuries. That's really why this talk matters. We want to recognize these if they have happened. With multiligamentous knee injuries, with knee dislocations, it's up to 40% of the people who suffer one of these injuries can have a vascular injury. And if there's a delay in diagnosis, the amputation rate goes through the roof. Even with recognition of a vascular injury, there's still as much as a 15 to 20% amputation rate with a vessel injury with a knee dislocation. So we have to recognize them. We have to have our radar up. And what do we need to do? We need to admit them to the hospital. One of the biggest mistakes we see is if these players come in, maybe their knee auto-reduced or it was reduced on the field, and now they come into the hospital, they get evaluated. We don't typically do MRIs acutely, so they have a relatively normal x-ray, swollen knee, and maybe they get sent out. If they had a knee dislocation and they have a vascular injury, they're going to have a problem overnight. They need to be kept in the hospital. They need to be observed. They need to be monitored to see if they indeed are having a vascular problem overnight in the hospital. So we need good communication between the athletic trainers, the EMTs, the receiving medical staff, because you guys saw it. You saw what happened on that video. You tell the EMTs or you tell your team physician, hey, this was a high energy injury. This patient may have dislocated their knee, and now our radar is up. We're paying attention, because if not, how often do we send someone to the ER? They end up in the ER, they sprain their knee, and they go home. That happens all the time. This is different. We just have to talk about it. In the ER, in the hospital, we do ABIs. That's an ankle brachial index. That's a crucial part of the examination. Okay, that's where we take the blood pressure in the arm and the blood pressure in the ankle, and we measure the systolic pressure and create a ratio. Okay, the systolic of the ankle over the systolic of the brachium, the arm. And you compare that ratio. That needs to be above 0.9. If it's below 0.9, we got a problem. Other concerns, nerve damage, certainly a concern and pretty common with these high energy mechanisms. And although it's not acutely an emergency, it is potentially a long-term problem, and it happens in as many as 25% of these injuries. 50% will never fully recover. If they've transected the nerve, this will make any surgeon vomit when they open up the knee. Okay, you see this nerve has been transected or avulsed proximally. That patient's never going to have a normal function as much as we try. We will do tendon transfers. They will end up in a brace, and they'll be able to walk and perhaps play again, but not at the same level. Compartment syndrome is another thing we worry about. With all the energy, all the swelling that can develop, a vascular injury, these patients can and do get compartment syndrome, and that's another reason to monitor them overnight in the hospital. The history is important, of course, with all that we do in medicine. And this one, there's not that much history that we have to discuss, really. I mean, you can't really miss that one. It is both knees, okay? And so that one you wouldn't miss, but the rest of them, we do need to know the history. We have to know what happened acutely, and then if they come into the office and it's subacute, we ask them, what's your instability? What are your mechanical symptoms? What are your limitations? Enough of that, right? So let's go back to our sideline evaluation. So of course, starts with the ABCs. You're all aware of that. Airway, breathing, circulation. Assess for an obvious deformity. And if there is one, don't be afraid to realign it. Okay, as Dr. Buckley mentioned, the coronal plane exam is very important. We're often worried about the cruciates, and that's probably perhaps the most common thing we'll see. But if they have that, plus a coronal exam instability, meaning varus valgus side-to-side instability, now our bells and whistles should start going up that this may be a more substantial injury. Neurovascular exam is very important. It can be hard to get that on the sidelines. The band and the noise and the cleats and the weather, but if they're describing some paresthesias or you're noticing some motor deficit, they're weaker on that side. start thinking that, hey, there may be more of an injury here. And if they have a nerve injury, they very well may have a vessel injury as well. So what do we do next? Knee immobilizer. Gotta have one. Gotta put them in a knee immobilizer. I'm a little surprised that some of the high schools I cover or that my kids go to don't always have the supplies that I would expect that we would. It's just not necessarily readily available, or it's been used up. There's a limited supply, but gotta have a couple of knee immobilizers in your chest, because that's what they need to protect the knee, to comfort them, but to protect the knee from further injury. Do take their cleat, their shoe, and their sock off so we can monitor that foot, certainly before any swelling sets in. Crutches would be helpful. As I've already mentioned, but I'll mention again because it's worth repeating, if there's concern over a knee dislocation or a multiligamentous knee injury, we want to get them to the hospital. We want to communicate with the family, with the receiving team, and we want to keep them overnight. So let's get into the exam a little bit. This is a really important part, comparing it to the contralateral knee. Very recently, I examined a lacrosse player on the sidelines who had a non-contact injury with a pop, twisted it in the middle of the field. He clearly injured his MCL, pretty significant MCL injury, and it seemed like he may have gotten his ACL as well. But when you compare it to the other side, he had a very loose, normal knee. And so my concern level went down a little bit, knowing that, hey, maybe he didn't just destroy his knee. That doesn't mean ignore what you're seeing, but just it ended up he had a significant MCL injury, and that was it. So we need to compare it to the contralateral side. We don't want to miss anything, obviously. And then a general rule is that we will examine the area that hurts the most last, to sort of keep the patient a little comfortable and try and do a thorough exam there. Signs of an acute injury, and certainly someone who shows up in your training room a couple days later, a hemarthrosis. If you see this amount of ecchymosis, obviously something significant happened. If they have a locked knee, those are all important factors to recognize. I was just talking with, was it Jackie? Who was I talking with about the patellar dislocation? Yeah, players often say I dislocated my knee, when in reality it was their patella that dislocated. Not to diminish that, that's a significant injury. We often have to operate on that, but it's a much different animal than a knee dislocation. And sometimes it can be hard to tell. Patellar dislocation can get a massive knee effusion, and they can be pretty painful. But this bottom video here, the apprehension test, if you try and sublux their patella laterally, and they have a lot of apprehension, pain, and like they're jumping off the table, that'll clue you in more that it was a patellar injury rather than a knee dislocation. Our Lockman's test, I think we're all pretty familiar with that. This patient has a pretty obvious one. This patient required a revision ACL, and this was their OR examination. So at 30 degrees, you're checking for anterior translation of the tibia on the femur, and you want to know if there's a firm endpoint or if there's a soft or mushy endpoint, or just sort of keeps going. Then we know that the ACL is probably injured. Sorry, missed one. This is a pivot shift. I don't know if that video will go. It's a pivot shift, which is very difficult to get on the sideline, almost impossible. And even in the training room, it would be difficult unless it's a chronic scenario. But this is one of our more important exams, and certainly we do it in the operating room. This knee is going from a little bit subluxed to reduced. When you go from extension to flexion with a valgus internal rotation maneuver, it's reducing. That's a chronic significant ACL. PCL, main stabilizer to posterior translation. We see these in isolation, perhaps when a fullback comes through the line and strikes a linebacker in the knee, you might get an isolated PCL. We see it with our more significant knee dislocations and high energy traffic accidents. And the dashboard injury is sort of a classic mechanism where the knee slams against the dashboard and the tibia translates posteriorly. So you want to check a posterior drawer maneuver. The top right one, this is a pretty significant posterior drawer. That's a knee that dislocates, but that's your posterior drawer. Can you do that one more time? That's your posterior drawer at 90 degrees. Okay, and the first part of it was a PCL injury, but the second part was really a knee dislocation. And then down below, the second one, can you get that one to play? The pseudo Lockman's test. You might not have heard of that one. It looks like a Lockman's test, but this patient has a significant PCL injury. Their tibia is translated. I might just have to advance it. No. Okay. What happens is a patient with a significant PCL injury or perhaps had a complete knee dislocation, you do their Lockman's test when their ACL is intact. It'll feel like they have anterior translation of the tibia on the femur, when what's really happening is you're pulling the tibia back to where it's supposed to be because it's translated posteriorly because it has a significant PCL injury. So we call it a pseudo Lockman's. You can get fooled. It wasn't that good a video anyway. Okay. So the MCL, perhaps we're all pretty familiar with that. That gets injured quite a bit in isolation and in combination with some of these other injuries, typically a valgus mechanism. You like to test that at 30 degrees of flexion with a valgus force, but also at full extension. If you have varus or valgus coronal instability at full extension, that's a problem. That means you got your collateral, but you also got something else, and that gives us a higher level of concern. Most commonly, it's a contact mechanism, different than our non-contact pivoting, despite what I just described about that goalie I saw. But a big part of it is, do they have an effusion or not? Usually they're not going to have an effusion if it's an isolated MCL. It's an extra-articular structure. So a bone bruise or a meniscus tear or an ACL in combination can cause an effusion. If they have no effusion, then we're pretty confident that it's probably just the MCL. Posterolateral corner, very well described by one of Dr. Buckley's mentors, Dr. Laprade, who described all these structures here, including the LCL, the popliteus, the popliteofibular ligament, and then the lateral gastrocs. This we will see with a varus mechanism, much less common than the valgus mechanism, or a hyperextension maneuver, or more of a complete knee injury with a knee dislocation. Important to know, right? The peroneal nerve is right nearby. So when you have a lateral sided ligamentous injury, pretty high chance you may have a peroneal nerve injury as well. A lot of maneuvers we do to check for that. A hyperextension maneuver here. We will assess for recurvatum, where we actually suspend the whole leg by the toe and see if it sags posterolaterally. That may tell you that there's a significant PLC injury. We're doing our varus test here, okay, in about 30 degrees of flexion, checking for the amount of translation from lateral to medial. And you do want to compare this to the contralateral side. You definitely can be fooled. That could be normal for some people. This is called a varus thrust gait. Is this going to work? This is a chronic PLC. And if you look at the right knee, sort of wobbles out when he walks. So he had a posterolateral corner injury that might have been missed or was ignored, but that's the result. And people don't like that too much. That's a varus thrust from a PLC. So imaging in the hospital setting, yes, we need x-rays, of course, both pre-reduction if it's not been reduced and post-reduction. We need an MRI. That's imperative to really see all the structures that are injured, the ligaments, the tendons. People will also dislocate their patella, so we check for that, the menisci, the cartilage, and is there a fracture? And then an angiogram, often that is necessary to evaluate the vascular status. Certainly Zach Miller had that. He had a vascular injury with this knee dislocation. He had an emergent revascularization. Ended his career. He had a nerve injury as well. From what I gather, he's still wearing an AFO, but he gets around pretty well. He's in a country rock band now. But the algorithm, if there's a knee dislocation or a multiligamentous knee injury, and I distinguish those there, just did it dislocate or not, but they're both in the same bucket. You got to reduce the knee joint. That will often be what is necessary just to reestablish the blood flow to the extremity, and that may be all that's necessary. But you still have to assess the distal pulses. Pulses are not enough. Just because they have pulses present does not mean there wasn't a vascular injury. We must obtain an ABI, and we drive that home to the residents, and they're very good about that here at our hospitals, to always check the ABI in any suspected significant knee injury, and that would include tibial plateau fractures. If distal pulses are present and the ABI is greater than 0.9, then we will observe that patient overnight, 24 hours in the hospital, keep checking on them, make sure nothing changes. If they are asymmetric pulses or the ABI is less than 0.9, they need an arteriogram. Any abnormalities with the arteriogram, then they may need a vascular surgery. And if there are absent pulses or clear signs of limb ischemia, they emergently go to the OR for a surgical exploration with the vascular surgeons. They get an angiogram on the table. This is just an irreducible knee dislocation. We do prefer athletic trainers and staff to try and reduce these if you can, straighten it out. If you see this pucker sign on the medial side of the knee, that's probably not going to reduce. Some of the MCL or the medial retinaculum has folded into the knee joint and will block your reduction. That's rare, but we see it once in a while. So in summary, multiligamentous knee injuries are relatively rare injuries. They can be limb threatening. Injury and history mechanism and the sideline evaluation are crucial. It's appropriate to realign or reduce on the field. It needs hospital evaluation and, once again, clear and repeated communication to the patient, the family, the receiving medical team is important to avoid a catastrophe. I'm just supposed to talk about initial management, but I have like 2 slides on what do we do next, in case you're wondering. So what do we do with these patients? So there's few options. Non-operative management really isn't a good option. They don't do well. However, once in a while, that's what we're forced to do based on various circumstances. The best option for that would be a brace with some early range of motion, and they can do okay, but not great. We will use an external fixator, mostly as a temporizing measure in someone who's just not ready for surgery. Perhaps the motor vehicle accidents with all their other injuries. We need to wait for everything else to settle down and them to recover from their head and their chest injuries before we can get to their knee. So we'll stabilize it in an external fixator. But really what we're talking about is operative treatment. We need to repair, or rather probably reconstruct the ligaments. It may be early, it may be delayed depending on circumstances. Sometimes we will do it in a staged manner, 2 or 3 operations, other times in a single stage. The goals are a ligamentously stable knee, have full pain-free range of motion, to return to activities of daily living. Can they get back on the field like Teddy Bridgewater did? Maybe, but oftentimes not. Can we prevent early arthritis? We like to, and we try to, but sometimes the horse is out of the barn on that one as well. The bottom line is these are highly complex injuries. Each one is unique. We do have to individualize their treatment based on everything else that's going on in their medical life, in their medical world, and really in their social world. But ideally, it's a single stage multi-ligament reconstruction plus or minus repair at the 2 to 4 week mark with early and aggressive therapy and range of motion. I know there's some therapists in the audience, and I know a lot of the athletic trainers here do a good job helping out with the post-operative management of these athletes. So what do we do in general? Early on, it's control of pain and swelling, full extension by a week. That's almost always our goal. Non-weight bearing for approximately 6 weeks. We do want to get to 90 degrees by those 6 weeks. If we did a PCL reconstruction, we like to do our range of motion flexion in the prone position to remove gravity sag stress on the PCL reconstruction. Several weeks later, we start working on strengthening, but we will avoid active hamstring strengthening until 8 to 10 weeks if we did a PLC reconstruction. Change the brace at about 6 weeks, and then please communicate with the doctors because this may be surprising. About 20 to 30% of these patients need a second operation. They may get stiff. It's somewhat par for the course, and we have to address it. It's not a failure. It's just what we sometimes have to do. Infections happen. Meniscus tears show up. So good communication with the MDs is important here. And then later on, agilities and sports-specific exercises, it's delayed compared to our typical ACL reconstruction. I would expect some kinesiophobia. Return to play is delayed greater than a year in these athletes. And then probably with a brace. I believe that's it. Here's my references, and thank you for your attention.